Hello there, my name's Nivian Sukirthan. I'm a final year graduate from Warts. Today I'm just going to go through the sexual health module of year 4. I won't be covering HIV, that's a separate topic. So what I'll be aiming to cover is basically how to take a good sexual health history, some of the sort of ethical guidelines on Fraser, competence, etc. And then we'll be moving on to the various sexual infections, chlamydia, gonorrhea, syphilis, herpes, and finally touch very briefly on HIV, and then we'll just go through some questions at the very end. Okay. So, sexual health history. So we aren't really taught much about it in years 1 to 3. It's when we get taught it in year 4. And so it's really important that you get to grips with the sexual health history because it's very likely to come up in OSCEs. So the presenting complaint can range from things like discharge, dysuria, urinary frequency, dyspareunia. So there's various types of presenting complaints. In the female, some of the more common complaints that they may come in with include vaginal discharge. So 4 questions to ask with regards to discharge would be the onset, so when it started, the colour of the discharge, whether it has a particular smell to it, and how much they're producing. Is it copious amounts? Is it just soiling their underwear? Do they have any abdominal pain at all? And just go through your Socrates for that. Pervaginal bleeding. So some of the sort of key things to ask would be intermenstrual bleeding. This would be bleeding that occurs in between periods. Postcoital bleeding, so bleeding after intercourse, and then heavy menstrual bleeding or menorrhagia. Urinary symptoms, that would include pain on urination. Are they going more often to pass urine? So you'll be looking at something like more than 7 times during the day or more than 1 or 2 times during the night. Have they noticed any anatomical changes over the genitalia? That could be sores, things like herpes. Lumps, they could be lymph nodes, or could indeed be warts, or even ulcers. Dyspareunia, so pain during sex, so that can be divided into deep and superficial. So deep causes of dyspareunia would include pelvic inflammatory disease, often caused by chlamydia, and endometriosis causing adhesions, and the uterus is less mobile, so that causes pain during intercourse. And you also have the superficial type, so herpes, for instance. And then we can go into the psychological implications of a presenting complaint. In the male, it's quite similar, but there's less to ask, really. So urethral discharge, again, there's 4 questions of onset, colour, odour, amount. Urinary symptoms, again, urinary frequency and dysuria. Testicular pain or swelling, again, anatomical changes to genitalia, sores, ulcers, lumps, bumps. Do they have any symptoms in their back passage? Changes in bowel habit. Again, Socrates for the abdo pain. And then finally, erectile dysfunction. That could be an organic cause, such as diabetes, vascular disease, or it could be psychiatric in origin. And then always, for any symptom that you are divulging into, you want to be asking about duration, associated features, aggravating, relieving factors, impact on life. Moving on to now partners. So you need to be asking, how are they currently sexually active? How many partners have they had in the past 3 months? When their last sexual intercourse episode was. Do they use protection or not? Bear in mind there are some sexual practices that don't tend to use protection, barrier contraception, such as oral sex. Unlikely that people use condoms. Any issues with intercourse at all? The type of sex practiced, and in terms of symptoms, we know that various infections have incubation periods, so we want to understand how long ago their last unprotected sexual intercourse encounter was. Was it with just one partner or several partners? How many have they had, as I said, in the past 3 months, male or female? Is it a regular partner? Are these partners from overseas? Is there any history from them? Things like, are they drug users? Are they involved in the sex trade? Do they themselves have any other sexually transmitted infection / HIV? And one final one to ask about would be, have you ever paid for sex? Again, they're more likely to catch an infection. Or have they ever been paid for sex? Okay. Now, moving on to contraception, this is particularly relevant in the female population. So, in terms of, pills, asking them what particular pill they're on, what dose they're on, making sure that they know about missed pill rules, are they compliant with their medication, do they know how to use it, etc. This really diverges more into past, sexual health history. So have they had an STI screen before? What was the outcome? And if they have been diagnosed with any particular infection in the past, such as chlamydia, gonorrhea, it has been shown that they're more likely to contract it again. So it would be relevant to ask when it was diagnosed, how they were treated, and whether they complied to the treatment. Moving on from the sexual history now to menstrual and obstetric history. So we've got an acronym for the menstrual history. So regularity. So how long do they bleed for? The average is around 5 days. 1 to 5 days. So how regular do the bleeds come? How long do they last for? And again, those same questions important to ask: intermenstrual bleeding, postcoital bleeding, and heavy menstrual bleeding. Underwear. So what I mean by that is, are the periods so heavy that it goes through to your underwear? Age at menarche, so when was your first menstrual period? And finally, when was your last menstrual period, if we're thinking about someone being potentially pregnant. Moving on to cervical smears. So have they had this done? Were they all normal? Did they require HPV testing? And any procedures done, like large loop excision of the transformation zone. And then obstetric history. So have you had any pregnancies in the past? Have they all carried to term? This would potentially be a good way of phrasing a question to make sure whether someone's ever had any terminations of pregnancy, rather than going straight into it, so ease them into that. Going through the pregnancies and complications, so if anyone has had a pregnancy in the past, making sure that there weren't any complications. What I mean by that is things like gestational diabetes, preeclampsia, high blood pressure, any issues with the delivery itself. Was it a difficult delivery? Did it require instrumentation such as forceps or Von-2s? Or was it a cesarean section, elective, or emergency? Things like that. Any previous terminations of pregnancy, miscarriages, etc. And also, is there any chance of them being pregnant at this very moment in time? Past medical history, you guys should be familiar with this anyway, but do they have any medical conditions that we should be aware of? Particularly in this history, it would be things like endometriosis and PID. Have they had any previous gynecological abdominal operations, which would increase the likelihood of the formation of adhesions, which would thus increase the chance of ectopic pregnancy as a pathology? Drug history. So are they on any medications? Do they have any allergies? Because this could implicate what antibiotics we can give for various infections. And are they on any contraceptive methods? Social history, smoking, alcohol, drugs, essentially. With drugs, take a bit of caution, because there are sexual infections that can be transmitted via bodily fluid contact through the use of sharing needles. This could be hepatitis, HIV, etc. Their profession, their living situation. Also, something to bear in mind: domestic violence and abuse. We know that that increases in proportion during pregnancy, so it's something to be tactful of and to bear in mind. Right, so once we've done the history, we need to be thinking about examination, and this would have been covered, I believe, during your or yet to be covered during your Obs and Gynae module. But basically, we're thinking about a PV and a speculum exam. So it's always about making sure the patient is comfortable, talking through the procedure, so mentioning to the patient that you'd like to perform a pervaginal exam. This will basically involve inserting 2 fingers into the vaginal passage and examining the womb, the cervix or the neck of the womb, your ovaries and the fallopian tubes. And because it's an intimate exam that you'd like to involve a chaperone for both the safety of the patient and yourself. And 3 questions always to ask. They follow the acronym BCD. So B for bladder. So emptying your bladder can make the examination a little bit more comfortable. Would you like some time to do that? C for chaperone, as I've already mentioned, and D for door. So it's a busy clinic, lots of things going around. Would you like the door to be closed or locked? So just giving them the option there facilitates that movement into a more comfortable examination for the patient. And then telling the patient the instructions of how to expose themselves for the procedure. So you say things like, I'd like you to undress from the waist down. There will be a gown there. There will be a towel there to cover your modesty. I'll be on the other side of the curtain. Let me know when you're ready. And could you please position yourself so that you can bring your heels to your bum? And let me know when you're ready. And then once all those formalities are dealt with, they'll call you in and then you can start the examination. So first of all, with a PV exam, always start with the abdomen. So feel the abdomen first of all to feel any lumps or bumps, as we were taught back in 2nd year, so nothing different there. And then say, right, so I'd like to now perform my pervaginal exam. Is that okay with you? And provided they agree, you remove the cloth, asking them to bring their heels to their bum and flop their knees apart. And then you examine the outer genitalia with the help of a light source, having a look at the vulva, vestibule, the urethra, the perineum. Also having a look for any ulcers, visible lumps, warts that you can see. And then have a feel, inserting your fingers, then have a feel for the uterus, the cervix, and is there any cervical excitation, etc. And then moving on to a speculum. So once you've dealt with a PV exam, you can do a speculum. Speculums are often done before the PV exam, actually. So again, the technique will be covered to you during the Obs and Gynae module, but the speculum is really there basically to visualize the cervix. And once you've done the entirety of the PV/speculum exam, tell the patient to get dressed, thank them for the examination, answer any questions, etc. You'd also want to think about sort of extragenital manifestations of STIs. So things like Reiter's syndrome, so urethritis, conjunctivitis, arthritis, so think about those various systems. Keratoderma blemorrhagica with chlamydia infection as well. With the male, so palpating the testes, things like epididymitis, epididymal orchitis would be relevant here. Having a look at the penis itself, phimosis, paraphimosis, etc. A sign that's relevant in examination of a male would be Friend's sign. So this is elevation of the testes, which would cause relief of pain in epididymitis, but it wouldn't cause any relief of pain in testicular torsion. So something to bear in mind. Having a look at the perineum, perianum, possibly even a proctoscopy examination. Palpate the abdomen as in the female, and then think about the extragenital manifestations, which we've already mentioned. Right, so once we've done examination, we'll probably think about doing some testing, etc. Along with testing comes partner notification. This is important because we know that STIs are very prevalent in the under 25s. It's very easy to transmit to various other individuals, so we need to stop the infection in its tracks. So that's why notifying other sexual partners of an individual with an STI is of paramount importance. Okay, this can be done in various forms. So the index. So index is the person that comes to your clinic. They themselves can inform their partner of the infection. Patient referral is so when the index person informs their sexual partner of their infection. Provide a referral, so where the health clinic themselves can contact the said partner in a confidential manner. So something like, we believe that you may be at risk of having a sexually transmitted infection. Would you like to come and get tested? Something along those lines. And I've already talked to you briefly about the positives of partner notification, but we're just basically trying to stop the infection in its tracks, prevent complications of an untreated sexually transmitted infection, particularly in the female population, subfertility, pelvic inflammatory disease, etc. And so, why do we bang on about trying to prevent STIs in the first place? Well, it can lead to unwanted pregnancies, and we want to encourage the practice of safe sex in the under 25s where STIs are highly prevalent. Moving on to Fraser Guidelines. Okay, so this is particularly relevant to your OSCEs. So it's something really to be aware of. So everyone should know by now, age of consent is 16 in the UK. If a patient is coming to you for advice regarding contraception or something along those lines and their age is below 13, that seriously needs to be investigated. Okay, Fraser Guidelines, so they were developed basically for an under 16 person, and there was a bit of haziness as to whether they whether the doctor can give contraceptive advice or contraception itself. So there's 5 bullet points that we need to be aware of with regards to Fraser's Guidelines. So the patient needs to understand what is being proposed. So they need to have sufficient maturity to understand its implications and complications. Number 2 would be giving advice on contraception is in the best interests of that patient. They're likely to continue to have intercourse whether or not you give contraceptive methods or it's advice. Their mental or physical health is likely to suffer if they weren't to get treatment. And finally, you've tried to persuade them to talk to their parents, but it's not working. Bear in mind, confidentiality needs to be maintained throughout. If, however, you're worried about said patient being exploited, you're worried about some kind of you're worried about the patient, you want to be talking to your seniors, child safeguarding, etc. Right, emergency contraception. So I believe this is also covered in the Obs and Gynae module, but to just touch on it briefly, when someone's coming in for emergency contraceptive, it's not good practice to simply hand it out. So there are things you need to account for in their risk factors, things like do they have a past history of breast cancer, DVTs, things like this, liver dysfunction, etc. Take a brief sexual and menstrual history, as we've already covered, and then you'll have to counsel them on how to take the tablet, and also use this as an opportunity to sort of educate them on safe sex principles, etc. So the tablets that we use, there's 2 main types. So there's levonorgestrel, or brand name Levanel. It's 1.5 gram dose of progesterone. It's a stat dose. It can be used up to 72 hours post-intercourse, but it's most effective if taken within 36 hours of unprotected sexual intercourse. And the good thing with Levanel is that it can be used more than once in a single cycle. LL1 is the other form of emergency contraception. It is a selective progesterone receptor modulator, and this is 30 milligrams, and it is a stat dose. This can be used up to 5 days after your unprotected sexual intercourse, but unfortunately it can only be used once in a cycle. They both inhibit ovulation and implantation of an egg. Some of the side effects to counsel patients on would be irregular bleeding, nausea and vomiting. Bear in mind, if a patient were to vomit within 3 hours of taking the tablet, they're more than entitled to take another dose. And just general breast pain, mastalgia, and pelvic pain, abdomen pain, etc. The most effective form of emergency contraception is not a tablet, it's a copper coil. This can be fitted up to 5 days after unprotected sexual intercourse, or indeed 5 days post ovulation, and can stay in there up to 10 days post 10 years. It can stay within the uterus for 10 years. How it works: it contains copper, as the name says, and copper is toxic to sperm, therefore inhibiting implantation. You can cover it with a doxycycline and azithromycin on insertion, because there is a chance of starting an ascending infection via the vaginal canal into the uterus itself, so cover with antibiotics. Some of the side effects, risks, include uterus damage, cervix damage, pain on insertion, infection, as I've already touched upon, expulsion of the device, and risk of ectopic pregnancy. So I think we have touched on this already, but these are some of the symptoms that patients present with, and there are some buzzwords that you need to be aware of. For instance, with vaginal discharge, if a question says something like curd-like cottage cheese, you need to be thinking of things like Candida. Bear in mind, Candida is not an STI. Watery, malodorous discharge. There are only really two infections that can cause this picture. They are both bacterial vaginosis and trichomonas vaginalis. Both also, apart from causing a malodorous discharge, also cause a rise in vaginal pH to above 4.5. Mucopurulent discharge would point towards a gonorrhea diagnosis, and a white/clear discharge would point towards chlamydia. Dysuria can occur with a variety of infections as listed there. Postcoital bleeding, intermenstrual bleeding, particularly with chlamydia and gonorrhea. Ulcers, painful ulcers, tend to be things like herpes, which is the commonest cause in the UK, but you've also got to think about syphilis, which can cause a painless chancre, trauma, bacteria, cancer, or even tropical diseases. Other things to consider: bar, discharge, lumps, etc. Lymph node enlargement, so you've got to be thinking about HIV here. Herpes, syphilis, lymphogranuloma venereum, which I think will be covered in the HIV side of things. Balanitis, so this is inflammation of the glands. There can be various causes of balanitis, but a common one would be chlamydia. Itchiness, so Sarcoptes scabiei, causing scabies, pubic lice, candida, etc. Swelling, tender testes, they tend to be gram-negative organisms, particularly E. coli, but they can also be STIs such as chlamydia and gonorrhea. Pelvic pain, dyspareunia, this should really point towards pelvic inflammatory disease, or even endometriosis if you want to go down that route. But if we are thinking of PID, the most common cause would be chlamydia, followed by concomitant or solitary gonorrhea, or even anaerobic infection. And then briefly on psychosexual dysfunction as well. So I've given you a brief sort of underlining of what infections I want to cover today. So the presentations of cervicitis and urethritis, you can see there's quite an array of infections that can cause those, likewise with genital ulcers and skin disorders. Vaginal discharge, as I've covered already, your curd-like or cottage cheese discharge with Candida, your malodorous thin white discharge with BV, TV, it has been reported to have a sort of green-yellow discharge about it as well. And bear in mind, as I've already said, BV and TV cause an increase in vaginal pH with a particularly bad odour to the discharge. Systemic conditions, so pelvic inflammatory disease, epididymitis, sexually acquired reactive arthritis, so this would be your Ratus syndrome with chlamydia infection, and prostatitis. Right, so now I'm going to start with the various infections. So let's start with chlamydia. So what chlamydia is, it's an intracellular bacterium. It can affect all sorts of mucosal surfaces, so that can be your genital tract, but also the rectum, the eye, and the throat. It's the most common bacterial STI in the UK. Unfortunately, the vast majority of patients are asymptomatic, so that's why it's got a very high transmission, because people go about their own lives without knowing they have an infection. It can present with postcoital bleeding, intermenstrual bleeding. It can give purulent vaginal discharge. It can give abdo pain, dyspareunia, dysuria, as well as proctitis. Some of the signs to be wary of are listed there, but cervical excitation would be one to note. Sukirthan, so these are sort of perihepatic adhesions which are related to pelvic inflammatory disease, would be a complication to be aware of. Symptoms in men, again, a lot of them are asymptomatic. But other symptoms to ring a few alarm bells would be urethral discharge, dysuria, testicular/epididymal pain, and proctitis. And once again, complications-wise, you're thinking of sexually acquired reactive arthritis. Again, both sexes, in terms of extragenital symptoms, can be proctitis, pharyngitis, and conjunctivitis. Diagnosis is pretty much NATS, so nucleic acid amplification testing. They can take the form of endocervical swabs in a female, or urethral/urine in males. You can test them any time, really. Doesn't depend on the symptoms. However, there is a window period. So if someone's had sex and they have contracted the infection, it can often take 2 weeks for that to present. So bear in mind that you may want to call them again and do a repeat screen. Treatment, 2 main antibiotics you need to be aware of: azithromycin, which you can give 1 gram orally, just stat dose, or a course of doxy for 7 days. However, in those who are pregnant, doxy is a teratogenic antibiotic, whether that be in pregnancy or breastfeeding, so just use azithromycin instead. I wouldn't worry too much about doses, just bear in mind the names of antibiotics and particularly classes. Alternatives, if you can't use azithromycin or doxycycline for whatever reason that may be, alternatives include erythromycin as well as ofloxacin. In pregnancy, some of the implications of a chlamydia infection for the child would include low birth weight. In the mother, postpartum endometritis, and in the child, once again, conjunctivitis, pneumonitis, etc. When a patient is taking antibiotics, avoid intercourse for a week at least, and until the partner has been notified and they may need treatment as well. And do a test of cure once you've given the course of antibiotics, often done around 6 weeks. And as I said, partner notification is paramount. Moving on to the second most common cause of an STI, this would be gonorrhea. It's a gram-negative diplococcal bacteria infecting mucosal surfaces similar to chlamydia, namely the genital tract, rectum, pharynx, as well as the eye. Gonorrhea is predominantly sexually transmitted. Perinatally, it can result in eye infection and often presents within the first week of life. Older children, if they are exposed to gonorrhea, you need to be thinking of sexual abuse. In terms of women, 50% are asymptomatic, so a bit less than chlamydia, but still quite significant. Discharge is very common, abdominal pain, dysuria, and abnormalities in menstrual bleeding, so particularly menorrhagia and intermenstrual bleeding. Some of the signs to be wary of would again be a discharge, a cervical excitation, a cervical contact bleeding, and PID. In men, they often present with a mucopurulent discharge, can have proctitis as well as dysuria. And signs, again, similar to chlamydia really, may be asymptomatic or may have no signs at all, but likely to have a discharge of some sort, pain in the epididymis, testes, and complications may include prostatitis. Depending on the mucosal sites, extragenital signs may include proctitis, throat signs, or indeed in the eyes. Something to be aware of actually for gonorrhea. Gonorrhea can present as a disseminated gonorrheal infection, similar to like a sepsis-like picture. It spreads predominantly by a hematological picture and can result in septicemia, arthritis, tenosynovitis, and skin manifestations. Diagnosis and treatment once again is via NATs, much like chlamydia. Gonorrhea does have a high resistance pattern, so it's very important to test for sensitivities to the various antibiotics. Treatment for it is a stat IM dose of Kef with a oral azithromycin dose, much like chlamydia. And once again, abstain from intercourse for a week whilst on treatment. And partner notification is of paramount importance. Non-specific urethritis. So this basically means it's a infection where you haven't been able to isolate a particular cause of the infection. So they can present with dysuria and or discharge and or urinary frequency. Symptoms may be intermittent, persistent, and they can vary in terms of their severity and how long they last for. It tends to be in men, but again, much like these other STIs, some of them don't tend to have symptoms. And it's even more prevalent in women with asymptomatic rates if men are transmitting it to females, and they of course have a risk of pelvic inflammatory disease. The vast array of causes for NSU include gonorrhea, chlamydia, mycoplasma, and TB. If you do isolate things like chlamydia and gonorrhea, the condition is no longer NSU, it's gonococcal or chlamydial urethritis. NSU is defined by not being able to identify a specific pathogen, and NSU is transmitted sexually through orogenital or genital-genital contact. Investigation and diagnosis. Usually it's a thorough history and examination here. Only symptomatic patients warrant investigation for the presence of urethritis. A sterile pyuria, which is basically white cells in the urine of a man with no particular bacteria, etc., with urinary symptoms, is indicative of NSU. Some of the tests that may be undertaken include a smear, culture, NATs, once again, urinalysis. We're just basically trying to exclude other causes of an STI before we jump to the NSU conclusion. Basically. Some of the complications of an NSU include Rater syndrome, prostatitis, subfertility, orchitis, as well as PID in females. Treatment, very similar drugs to treating chlamydia and gonorrhea, just because those are the main causes of NSU. But if it's an uncomplicated first presentation, you're going to give them doxycycline, azithromycin, or ofloxacin, either one of those. For a recurrent infection, you want to step up your treatment, so doxy and metronidazole, or azithromycin and metronidazole. Partner notification is important to a certain extent. It tends to be confined to male patients, NSU, but once the diagnosis is made, you want to be looking at your other sexual contacts and treating them as well. And current and recent partners within the last 3 months need to be screened and treated. And as with many of the other infections I've covered already, you should avoid intercourse whilst being treated for it. Herpes. So this is a virus. 2 main types to be aware of. 1 and 2. 1 predominantly causes orolabial symptoms. 2 causes anogenital. Transmission is via close physical contact that can be sexual or indeed orogenital. The virus is only transmitted when someone is shedding. Okay, so one may have herpes, but if you're not shedding the virus, you can't really transmit it to another person. And again, it can often happen asymptomatically, so someone can be shedding the virus without really presenting with any particular symptoms. Presentation. So on the initial side of things, only 1 in 3 people develop symptoms at the time of transmission within 2 to 12 days. The other 2 in 3 are asymptomatic and can present with symptoms far later because they are aware of their partner presenting with symptoms, and so that arises some suspicions. Symptoms in both males and females include a febrile prodrome, just like a general viral illness that can last for up to a week. They may have urinary disturbances. There may be lymph node enlargement, which can be painful. And typically you have herpetic neuralgia or neuropathic pain, which tends to be isolated in the genital area, the buttocks and the legs, as well as blisters, ulcers and fissures. If untreated, the first episode can often last up to 3 weeks plus, actually. Complications, so they tend to be related to the pain, the ulcers, etc. So if you imagine if someone's getting pain on urination, a burning sensation, they may go into urinary retention because they don't want to pass urine. Constipation with regards to perianal disease, and it can actually lead to a meningitis, a herpetic meningitis. So recurrent episodes, in terms of the symptoms they present with, they include a neuropathic sensation of tingling, burning, etc. that I've already mentioned. Blisters, fissures, ulcers, etc. But they should resolve within a few days. The risk of symptomatic recurrences is far greater augmented in patients who are young, who had a really severe first episode. And within 3 months of their primary episode. And if they've got any other conditions that poses them to a far greater risk of infections, things like HIV or immunosuppression, that would also bolster their chances of having HSV recurrence. Diagnosis is pretty much through PCR swabs. Don't delay treatment just for the sake of taking a swab. Just because you have a negative test, it doesn't exclude HSV. HSV serology isn't really performed, but you can consider it in pregnancy. So the treatment for it, so it's best to commence treatment quite early. So once you've got those lesions, you want to be starting things like antivirals such as acyclovir pretty much for 5 days. Other sort of methods you can do just to deal with the pain, I guess, is really just analgesics, laxatives if patients have got perianal symptomatology, bathing in saline, and also lidocaine ointment has also been warranted. Antivirals, bear in mind they just reduce the severity and duration. They don't alter the history of the disease or indeed the severity or the recurrences. And counselling the patients on these medications is vital. And we've touched upon recurrence already, but things like, the recurrences tend to be less severe than the first episode. And it doesn't really need antivirals. Saline washes, analgesia can help with that. And referral to gum clinic if you're really worried about the patient, and that can be helpful. Now, moving on to warts. So warts tend to be caused by HPV, human papillomavirus. There are very, very many types of HPV. I think there are about 100 subtypes. But there are only really 30 that are associated with genital infections. Of the numbers I've listed there, 16, 18, 31 and 33 subtypes of HPV tend to cause cancer of the genital tract, particularly the cervix as well as the anal canal, whereas it's 6 and 11 that tend to cause warts. The cervical screening program doesn't really need to change just because someone has warts. There doesn't seem to be much correlation there. And in terms of transmission, it's similar in the sense with herpes actually, because it's transmitted through close physical skin-to-skin contact when someone is shedding the virus. Pretty much really. So there you are. In terms of symptoms, signs, diagnosis, etc. So it's pretty much the lumps really that is the major symptom / sign to be aware of. The lumps can vary in size, shape and colour. can actually be quite itchy, pruritic, can cause obvious visual discomfort, may bleed, especially if it's near the urethra. Hyperpigmentation may be present, especially if someone has been irritating the area. Diagnosis is pretty much clinical and it's based on the appearance. But if you do have any doubt, make sure to take a biopsy. Okay, so although genital lumps can be caused by HPV, some of the things that you need to be just wary of include molluscum contagiosum, caused by pox virus, papillae on the vulva, sebaceous cysts, scabies, which would cause intense pruritic picture, or it could just be anatomical variants that doesn't really warrant any further investigation. Treatment for this, so you want to basically try and get rid of the warts, but you can't really get rid of the virus because it remains latent. So even if someone doesn't have warts, they can still be infectious. So the recommended management includes sort of creams, body full of toxins. Avoid this during pregnancy. So cryotherapy is preferred actually during pregnancy. For cervical warts, colposcopy would be a method to try and remove them. Cryotherapy, as I've touched on, can be used for oral warts. And referral to genitourinary medicine clinic if you're particularly worried. Pregnancy, the treatment tends to be difficult because we can't use things like imiquimod, body-full of toxins, because we're worried about teratogenicity. Therefore, it's really cryotherapy that's tends to be used. In terms of vertical transmission for women undergoing vaginal birth, vertical transmission appears to be extremely low. Therefore, the presence of warts doesn't tend to pose a big management factor when dealing with delivery. However, if the warts are particularly large and may obstruct the passage of delivery, then we may need to consider a change in management plan. And monitor the patient with a follow-up just to check whether the treatment that you've administered has been effective and they're responding. Partner notification doesn't tend to be of much benefit here. Right, syphilis. Syphilis is caused by a spirochete bacterium known as Treponema pallidum. It is transmitted via direct contact through an infectious lesion. Can be via sexual intercourse, or even via vertical transmission during pregnancy, because it can pass through the placenta. It can be transmitted genitally or extragenitally, so through oral-anal or genital-anal or oral-genital contact. Syphilis tends to be highly predominant in men who have sex with men, particularly in the ages of 25 to 34. And it has been found that they tend to also have HIV co-infection. So this is an important distinction here. So syphilis can be split up into primary, secondary and tertiary. So primary is what you're thinking of is the chancre. Yeah, so it's the sort of non-painful ulcer that patients often get. It's non-purulent. In some people it can be multiple, painful and purulent, but this doesn't tend to be on the genitalia. And it resolves within 3 to 8 weeks. If it isn't treated, primary can progress to secondary in 1 in 4 patients. And secondary is really to do with organ issues. So that could be liver, spleen, kidney, neurological in the sense of meningitis, cranial nerves, optic neuropathy, uveitis, retina involvement, etc. You may also get skin manifestations, so a mucocutaneous rash, itching on the palms and soles, mucus patches on the mouth. You can have latent disease, So your secondary syphilis, as I've just mentioned earlier, that resolves over, a good 3 to 12 weeks. It enters a latent stage, but it can recur into a secondary stage in 1 in 4 patients. And finally, the tertiary stage occurs very many years after the initial infection in 1 in 3 patients, and it can lead to sort of mycotic aneurysms, aortic regurgitation, dementia, tabes dorsalis, and general paralysis of the insane was the older term for a presentation in tertiary syphilis. The diagnosis and treatment of it. So you can swab lesion to identify the spirochetes bacterium, the Treponema pallidum. You may also want to do serology. Have a look at IgM, IgG. IgM being the antibody prevalent in acute infection, IgG indicating past infection. Major treatment for syphilis is benzathine, penicillin. There are some others there, doxy, kef, amox, if you can't use the penicillin. For late syphilis, again, benzathine penicillin is the major treatment, and again, if you can't use that, you've got things like doxy, amox, probenecid. And again, partner notification is of great importance. So vaginal discharge. So apologies, it's been cut off from the very end. I'm just going to make sure that's viewable. So vaginal discharge. Okay, sorry about that. Okay, so with vaginal discharge, so there's 2 main things you need to consider here. It's Candida and BV, okay? So the etiology of both are quite different. So Candida is a fungal infection, can cause an inflammatory dermatitis of the vulva and vagina, and can be associated with vaginal douching, perfume soaps, tight clothing, and it can often be associated with treatment with antibiotics because it changes the flora of the vagina as well as pregnancy. It causes a vulval itch, tends to be a bit sore, can cause, as I've mentioned earlier, cottage cheese-like discharge with superficial dyspareunia. In terms of diagnosis or investigations, we're thinking about high vaginal swabs from the anterior fornix. And treatment-wise would just be really avoid risk factors, as mentioned earlier with the perfume soaps, the douching, etc. Antifungal creams, pessaries, tablets. Bear in mind things like fluconazole are teratogens, so don't give them orally during pregnancy. The other major cause of a discharge picture is BV. So this is not an STI. It is caused mainly by a change in the flora of the vaginal canal. It has a very similar picture of risk factors to Candida, so vaginal douching. However, there are other risk factors, so changing of partners, smoking, presence of concomitant STIs, receptive cunnilingus as well. The pH for BV is typically elevated to above 4.5, very much like Trichomonas, but Candida pH tends to be normal. The discharge in BV tends to be offensive, thin and white, as opposed to the non-offensive cottage cheese-like discharge with Candida. In BV, it can give a fishy odour, typically post-intercourse because of the proteolysis of bacteria, which causes amine production. Symptomatic individuals may warrant vaginal swabs. You may find clue cells. Clue cells are basically vaginal epithelial cells studded with bacilli on the surface. In terms of treatment, the major treatment is metronidazole. If metronidazole isn't tolerated, clindamycin would be an alternative. And with metronidazole, bear in mind you can't have alcohol with it. Okay. Right, back to here. I'll just change to full screen. Okay, so bacterial vaginosis grading of microscopy. So, as I've already mentioned, bacterial vaginosis is caused by a change in the flora in the vaginal canal. The major bacteria to predominate in the vaginal canal is Lactobacillus, and this would be grade 1. If this were to change into other bacteria such as Gardnerella or Morbilluncus would go into stage 2, and then if they outnumber the lactobacilli to a far greater extent, then this would go into grade 3. Right, trichomonas. Trichomonas is an infection of the vagina and urethra, but this is caused by a protozoa, not bacteria. Men and women can both be affected, and there seems to be some rates of co-infection with TB and HIV. In terms of the symptoms, it causes a discharge, can be green and yellow in colour, with itching, dysuria, an offensive odour, very much like BV as I've mentioned repeatedly, and can cause a strawberry cervix with sort of punctate like bleeding points on the cervix. The history is pretty much all you need to sort of have a suspicion for trichomonas if they're symptomatic, but the best form of diagnosis is a swab from the posterior fornix, or indeed a culture or a urine or urethral culture if it were to be a male. Partner notification is once again important, abstaining from intercourse for 7 days until partners are treated, and treatment is metronidazole. Okay, so this is really obs and gynae knowledge. I'll just touch on it briefly. Pelvic inflammatory disease is an infection in females caused by an ascending infection from the cervix, causes of which include chlamydia, gonorrhea, anaerobes, mycoplasma, and strep. Features, so pelvic inflammatory disease, you've got acute as well as chronic. So acute would be less than a month, chronic more than a month. And it has various complications. Salpingitis, which is the fallopian tube infections, parametritis around the sort of fascia surrounding the pelvic organs, oophorytis with regards to the ovaries, an abscess forming in the tubes, or indeed a peritonitis picture. Risk factors for PID include the age group that are at high risk of STIs, namely under 25s, several sexual partners, not using barrier contraception, terminations of pregnancy, excuse me, and recent contraceptive device change, as well as a miscarriage. Signs and symptoms, it's deep dyspareunia, that is the clue here. Pelvic/abdominal pain, intermenstrual bleeding, postcoital bleeding, and a discharge. Signs would be a cervical excitation, adnexal tenderness. There may even be a low-grade fever. The sort of consequences of an untreated infection include chronic pelvic pain that can traditionally be very difficult to treat, ectopic pregnancy, what with the adhesions that may form, and infertility. There's no real definitive diagnostic criteria actually for PID, but the major thing is to just avoid delaying treatment as much as you can. Just try and treat them quickly to avoid those major complications as I've outlined previously. In terms of investigations you may want to consider, judging by the causes of PID, would include NATs to isolate gonorrhea and chlamydia, endocervical microscopy swabs, urinalysis, pregnancy testing, MSU specimen, and pelvic ultrasound and laparoscopy. For those who don't respond to normal therapy, you want to be thinking about those two. Fine. Treatment is basically antibiotics. So it's ceftriaxone, doxy, and metronidazole, or ofloxacin and metronidazole. And you review them in a few days' time, especially if they've got a higher grade of infection, and you may want to continue antibiotics for a few more weeks yet. And if antibiotics haven't worked, or if the patient is sufficiently severe in presentation, you may want to consider inpatient management. So some of the circumstances where that would happen is if there's a diagnostic uncertainty, they are having a severe presentation despite treatment. They have a tubular abscess. They may be immunocompromised. They can't tolerate oral antibiotics, and you may want to give them IV antibiotics. And the antibiotics used are very similar: ceftriaxone, doxy, metronidazole. Male partners, in terms of partner notification, should be informed and screened, even if you can't find a particular organism in the female, and treated with broad-spec antibiotics. And avoid sexual contact until treatment has been completed. Last few slides now. So epididymitis, orchitis. So this is pain and swelling of the epididymis with testicular inflammation. Tends to be caused by gonorrhea, chlamydia, in the under 35s. In the over 35s, with those who don't tend to change sexual partners, it tends to be E. coli and gram-negative bacteria that tends to cause the infections. TB as a cause is very rare. The features of it is a unilateral testicular pain with friend sign, as I mentioned earlier on in my presentation. Complications include a reactive hydrocele, abscess formation, and infertility. Differential diagnosis. So the major one we need to be thinking about is torsion. But with torsion, there tends to be a history, a very, very acute history of trauma, perhaps. It tends to be younger as well, and is acutely painful, with friend sign not basically relieving pain if the testes were to be elevated. And to treat that, you need urgent surgical exploration. Inguinal hernia, so you've got two major age groups. You've got the young children who tend to have the patent processus vaginalis, forming an indirect inguinal hernia. Or you've got the older population with a defect in the abdominal wall through Hesselbach's triangle, forming direct inguinal hernias. With either one, you basically can't get above the hernia. You can feel a lump, and there are various tests, things like a cough impulse, etc. Or it may even be a tumour. But with tumours, you can have a look at ultrasound scanning as well as tumour markers, things like AFP, HCG, etc. To screen for seminomatous tumours and non-seminomatous germ cell tumours. Investigations for epididymitis specifically would include a first-pass urine sample for chlamydia and gonorrhea, because we know this is the major cause in the under 35s. Midstream urine sample to test for UTI and TB, which is a very rare cause. Serology, HIV, syphilis, mumps. Ultrasound for torsion, but as I've already mentioned, never delay urgent surgical exploration for torsion. And refer to urology if you are worried about structural abnormalities. Treatment is general rest, analgesia. Abstain from intercourse until they, as well as partners, have been treated if it's a severe infection. And if it's an inpatient admission, treat with fluids and electrolyte management. If STI is the likely cause, the drugs used are very similar to the drugs used in gonorrhea, PID, etc. So these are ceftriaxone, IM dose, doxy, or ofloxacin. If it's a UTI that you think is the major cause, ofloxacin or ciprofloxacin can be a good starting point. Review them in a couple of weeks. Continue therapy for a month if it hasn't really worked, because recovery can take some time. If still the antibiotics haven't really had an effect, make sure that the patient is actually taking the antibiotics properly, that they haven't had intercourse in the interim period, and they haven't been reinfected. Fine. And if it's a urinary infection, partner notification isn't really needed. But if it's a STI related, then yeah, partner notification is needed. Finally, we'll just go through a bit of viral STIs. Hepatitis. So hepatitis A, C, and B is what I'll try and cover today. So hepatitis A, the serology isn't really that complicated. It's IgM and IgG. IgM really for the acute infection, IgG for the past infection. Hep C, Hep A tends to be transmitted via fecal oral transmission. Hep C is via body fluids, can produce a chronic picture and can often lead to hepatocellular carcinoma, particularly in the UK. Can offer antibody testing for those who are at risk, like drug users, those who have suffered sexual assault, those who have HIV infection, Hep B infection, those involved in the sex trade, those who have had tattoos, or those who have received blood transfusions pre-1991, and those from high-risk areas of the world, such as Southeast Asia, Eastern Europe, Egypt, Pakistan, as well as China. That's pretty much it. So Hep B. So this serology, the serology sort of facts on this slide would have ideally been covered in year 3 under the gastroenterology module, Met 3A. But just a recap, really. So HBs antigen. This is the surface antigen. It's the first one to appear when someone were to be infected with Hep B. And if it lasts for under 6 months, it's an acute infection. Any longer than 6 months, it's a chronic infection. Anti-HBs implies immunity. So if someone's had a vaccine for Hep B and that's about it, and they haven't had the infection at all, they would have anti-HBs. Anti-HBC is HBC for core, implies previous or indeed current infection, and therefore you need to sort of delineate that using IgM and IgG, with IgM being recent and IgG being past infection that persists. And finally, HBe antigen is indicative of someone that is extremely infective for hepatitis B. Now, final bits on HIV. So, why we need to test. So, HIV, as I said, should be covered in more detail in the handbooks on QM+, or indeed if there's any more lectures on here. So I'm just going to touch on it briefly, not in too much detail. So why you want to test people for HIV. We know that HIV can be transmitted via IV drug users who share needles, through sexual transmission. It can have very severe implications on patients' well-being and quality of life, so it's important to test them. If someone suffered sexual assault, part of the routine antenatal screening program, as a routine during blood donation as well, as part of a routine medical examination, pre-op assessment, etc., or even in the workplace for medics, nurses who may have been exposed to bodily fluids. Bear in mind, as with any test, patient consent is required, but sometimes it may be in the patient's best interests. So things to discuss pre-doing the test. So get their consent, assess their risks, talk to them about why it's important to do the HIV test. Promotion of health is vitally important, and think about partner notification. So again, some of the risks associated with risk factors for HIV, men who have sex with men, again, they may have concomitant syphilis infection, IV drug users, places where heterosexual HIV infection is prevalent, and those who have received blood products. Fine. So in terms of how you test for HIV, so it's antibodies as well as antigens, and they each have their own window period. So the P24 antigen often can be detectable within a month, 2 to 4 weeks actually, and the antibody becomes positive around 4 to 6 weeks. So therefore it's best to inform patients of a window period of 6 weeks. So if someone has been infected with HIV, they may not be positive immediately, but may be positive 6 weeks after. So it's always worth asking them to come back in that time frame, pretty much. So that's all pretty much it for theory of sexual health. I appreciate that was quite a lot of material covered there. What I'll try and do now is basically go through some of the questions relating to sexual health that were covered in the Sexual Health Leads lecture, the review lecture. There's 5 EMQ style questions that will come up here. I believe my slides will be uploaded onto whatever page PAL has, so you'll find all the notes for the presentation underneath, as well as the explanation for the various questions, but I'll go through them briefly now. So if you have a read of the following questions. Okay, so question 1. I hope you all have had enough time to read through the questions. I'll just go through them briefly. The answers are on the next page. As I said, sort of the rationale behind each question will be in the notes underneath the slides. So question 1. A sexually active woman with profuse offensive green discharged used a clotrimazole pessary with no effect 3 weeks before presentation. Vaginal pH is 6. So the key things to highlight here: it's a green discharge, the pH is raised, so it should be C, TV. Question 2. An 18-year-old man who recently had anal sex with another man, I believe it's a typo there, presents with a perianal ulcer, and it isn't particularly tender. Sorry about that. So presents with a perianal ulcer but isn't tender, so this is likely to be a chancre, so that would be H. A 25-year-old with offensive white discharge, no itching, so you need to be thinking about the offensive white here. She's got frequent bubble baths, douches, so those are risk factors. She's had it previously and notices it after unprotected intercourse, so that should be no. Okay, so the answer would point towards BV, because we're thinking about an offensive white discharge and the risk factors said there. Question number 4. A 20-year-old lady with a 2-day history of increasing vulval soreness and external dysuria, unwell, feverish, with a blister on her vulva. So the unwell and fever would point towards a viral prodrome. The blister, the soreness, the ulceration would point really towards herpes. So that's I. And then finally, a pregnant woman with itchy, thick, white discharge, vaginal soreness. They don't mention odour. It's thick, it's white, probably cottage cheese-like, so that would point towards Candida. Okay, set 2, if you have a read of that. Okay, hopefully you will have read that in the time allocated. So, question number 5 here. A 28-year-old pregnant woman has white vaginal discharge and vulval itching. Her pH is 4. And microscopy revealed pseudomycelium and spores. So first thing to note, white vaginal discharge, so we're thinking either BV, Candida, things like this. Itching, so again Candida seems likely. Her pH isn't raised, and you've got fungal-like picture on the microscopy. So we need antifungals, so the right answer here would be clotrimazole pessary. Question 6. A 35-year-old woman with white offensive vaginal discharge. So you need to be thinking about something like BV. She was treated with an oral antibiotic for a previous episode during which she developed an itchy rash all over her body. She can't remember the antibiotic, but knows that she wasn't allowed to drink alcohol while taking it, so that was likely to be metronidazole. There's a white offensive discharge on examination with a raised vaginal pH as well as clue cells on microscopy. So it's pretty obvious this is BV. If metronidazole isn't tolerated, the next appropriate step in management would be clindamycin. So that would be D. Question 7. A 22-year-old woman has a 1-week history of profuse vaginal discharge and vulval itching. Examination reveals an excoriated, inflamed vulva and profuse green discharge and an inflamed-looking cervix and a strawberry cervix. So strawberry cervix should point towards TV. You've got the profuse green discharge again, which would point towards that diagnosis. First-line management would be metronidazole, that's B. A 19-year-old man whose partner has been diagnosed with chlamydia trachomatis. So this is sort of like a partner notification type scenario. So we would treat them with C, that's doxycycline. Bearing in mind doxycycline and azithromycin both can be used to treat chlamydia. And finally, a 25-year-old man with 4 or 5 blister lesions on the shaft of his penis. He hasn't had this before. So this is likely to point towards acyclovir because it seems that this is a herpetic picture. However, we have got 2 acyclovir options there, so the correct one to choose would be the tablet or option J, and this is because any treatment for herpes would be a systemic treatment. It wouldn't be local treatment with cream, so the answer would be J. Okay, set 3, if you go through this. Okay, so question 1. A 35-year-old man had unprotected intercourse with a male partner 4 weeks earlier. He presents with malaise, fever, lymphadenopathy, small mouth and penile ulcers. On examination, there is a disseminated macular rash involving the palms and soles. So the answer here would be H. Secondary syphilis. So I'm saying this because you have the ulcer, which would probably be the chancre initially. The macular rash involving the palms and soles is characteristic of secondary syphilis, as is the general sort of malaise, fever, etc. Question 2. A 31-year-old pregnant HIV positive woman with a fever of 38. Sorry, give me a second. Yep, so with a fever of 38, she recently commenced Truvada and Nevirapine, which are heart therapies, to reduce risk of vertical transmission of HIV. The answer here would be a drug-induced rash, so B, drug reaction. Question 3. A 44-year-old man, HIV positive, with erythematous painful vesicles on his left buttock and shooting pain down his left leg. So you've got to be thinking about the neuropathic pain going down his left leg. You've got the painful vesicles as well, or blisters, whatever you want to call them, on his left buttock. So you need to be thinking about C, so herpes zoster virus. So why this isn't herpes simplex virus is because it's the dermatomal picture. So person with HIV positive, so they are immunocompromised, so they're more likely to have a herpes zoster or varicella zoster's infection that can present on a particular dermatome. Okay, whereas HSV, herpes simplex, would be, the orolabial anogenital presentation, which would be slightly different. Okay. Question 4. A 41-year-old woman with vaginal discharge for 4 weeks and pustular lesions on her hands and trunk. Okay. So the answer for that is A. That's a disseminated gonococcal infection. Okay. Bear in mind we discussed the gonococcal infection for the DGIs can spread through hematological pictures, through a hematological mechanism, can present with things like arthritis, sepsis, tenosynovitis, etc. And final one, on set 3, a paediatric nurse with severe itchy lesions on her limbs and trunk and a small red macule in her finger and web spaces. So this is characteristic for J. scabies because these organisms tend to cause linear burrowing in between the webs of the fingers, basically, and cause severe pruritus. So that should be J. Yep. Okay, set 4. If you pause the video here and restart when you're ready to start, so I'll go through the answers shortly. Okay, so question 1, a 17-year-old man with multiple warts on the shaft of his penis. So in terms of the first line treatment for that, that would be B, polyphyllotoxin. So we're thinking about HPV here. Question 2, a 21-year-old pregnant woman with inguinal lymphadenopathy with small, shallow, painful ulcers around the fourchette. She hasn't had this before. So question 2, the answer would be A. So this is herpes. Question 3, a 37-year-old pregnant woman with several large vulval warts. So we've got a pregnant woman here, so we can't be using things like imicromod polyphyllotoxin because we're worried about teratogenicity. So we need to be using cryotherapy. C. An 18-year-old man with pearly penile papules. So these are self-limiting. They don't really tend to cause much problems apart from just visual changes. So therefore, since it's self-limiting, there is no treatment. So answer is H. And finally, a 19-year-old man with multiple pinkish umbilicated lesions on his penis and scrotum. This points towards molluscum contagiosum caused by pox virus. No treatment again, so the answer would be H. Final one, set 5. So if you have a look at the questions, pause the video here so that you've got some time to think for yourself and restart when you're ready. Okay, so question 1, unilateral painful swelling at the vaginal opening. So painful swelling, you may be thinking it's herpes as well, but they're not really talking about an ulcer as such. So anything else that could potentially cause pain, chancre is painless, usually, so it would probably point towards an abscess. So that would be A. Bartholin's abscess, and you treat that by drainage through something called a marsupialization procedure. Question 2. A single non-tender ulcer on the tongue in a man who has sex with a man. That would point towards a syphilitic chancre. It's a non-tender ulcer, so that's a clue there. And we know that syphilis can present in various mucosal surfaces. Number 3, discrete exophytic. Just bear with me a second. So 3 discrete exophytic ulcerative lesions around the vaginal entrance of a pregnant woman. Okay, so that answer would be E. Genital warts. So it's around the vaginal entrance, so that would point towards a wart. We're not told that it's particularly painful, etc. So that would point against something like a Bartholin's abscess. Question number 4. Pinkish umbilicated lesions on the face of a severely immunocompromised HIV positive man. So umbilicated should really point towards molluscum contagiosum. Because it is on the face, which is actually very uncommon, this points towards quite a severe case of HIV. And final one now, indurated, rolled edge, non-tender, single ulcer under the foreskin of a 75-year-old man. So the answer here is B. So the reason why it is this is because it's an indurated rolled edge. This is often a term used to describe a BCC type of cancer, a basal cell carcinoma cancer. And he's an older man, so cancers are of course higher risk in the older population. So that's why it would point towards a cancer of the penis. So those are the answers for set 5. So that's it from me really for the sexual health lecture. Thanks very much for tuning in and listening to this presentation, and good luck. And please do refer to the sexual health lectures as well as the sexual health handbook, which is the major source which I use to compile these slides. Thank you very much.